Good morning and welcome to the fourth meeting of the COVID-19 Recovery Committee in 2022. The first item on the agenda is consideration of the latest ministerial statement on COVID-19 and subordinate legislation. I'd like to welcome the Deputy First Minister to the meeting and his supporting officials. We have John Swinney, Deputy First Minister and Cabinet Secretary for COVID Recovery, and Professor Jason Leach, National Clinical Director. Deputy First Minister, would you like to make any remarks before we move on to questions?
Thank you, Convener. I'm grateful to the committee for the opportunity to discuss the recent developments in relation to updates to Parliament on COVID-19. As the First Minister set out on Tuesday, recent data continues to give grounds for optimism. The situation we are now in is much less severe than we had anticipated, although it is important to note that case numbers remain high and we've seen increases in some age groups. The significant fall in cases during the first 3 weeks of January is now reflected in a fall in the number of people being admitted to hospital, and thankfully the number of people with COVID in intensive care has also reduced. These improving trends are as a result of the booster vaccination programme, the proportionate measures introduced in December and the willingness of the public to adapt their behaviour. This has enabled us to remove virtually all of the additional protective measures introduced in December. We are continuing our cautious approach to lifting protective measures. This week we have issued guidance for employers regarding hybrid working, where it can be done safely. From the 11th of February, fully vaccinated travellers will no longer need to take a test on their arrival into Scotland. This week the Cabinet agreed to retain wider baseline measures, including the COVID certification scheme, the collection of contact details in hospitality settings and the requirement to wear a face covering in many indoor places. We are also asking the public to continue to take lateral flow tests before mixing with people from other households and to ensure they report the result online. These measures are important while the NHS remains under acute pressure. The number of people in hospital with COVID is falling, but it is still double what it was just before Christmas. The Advisory Subgroup on Education and Young People met recently and refreshed guidance was published on Tuesday, and we will monitor the advice on face coverings in schools and early years settings. The group will consider this issue again at its meeting on the 8th of February. COVID vaccinations have now started for 5 to 11-year-olds at the highest clinical risk and those who are household contacts of someone who is immunosuppressed, in line with the most recent advice from the JCVI. Flu vaccinations have now also resumed for higher risk groups after being paused in December. As we look ahead to spring, we can continue to be optimistic, and evidence shows that we may be entering a calmer phase of the pandemic. The revised strategic framework will be published after the February recess, setting out in some detail our approach to managing COVID more sustainably in future phases of the pandemic towards the virus hopefully becoming endemic. And I'm very happy to answer questions from the committee.
Thank you, Deputy First Minister. If I could ask the first question, I think that very welcome news that we're moving into a different phase. This committee is called the COVID-19 Recovery Committee, but since we've been established, we've been dealing with the fluid situation of COVID and not being able to really focus on recovery. As we are moving into a different phase, do you think that maybe it's time to stop publishing daily figures?
I think that's it's an issue we'll have to come to, Convener, to consider. I think at this stage, my answer would be firmly no. I think we have to continue with that daily publication of information to inform the public about the state of the pandemic. You know, although the outlook is much better, there are still, on average, in excess of 6,500 to 7,000 cases on a daily basis, and if we go back to previous periods of the pandemic, these numbers would have absolutely horrified us. But obviously there's an awful lot more protection within the population through the booster vaccination programme. So we will consider these issues, but certainly at this stage I think it's important that we continue to furnish the debate with that quality of information to ensure that there is a transparency around the state of the pandemic and the decisions that government has to take in the light of that data.
Okay, thank you very much. I just want to move on to the hybrid working as we move forward. I think we all recognise there have been huge advantages to the flexibility of hybrid working, but on the flip side, it can also be really difficult for employers and indeed people struggling to work from home. And of course, the long-term impact on things such as footfall in our town centres. Can I ask the Scottish Government how it's assessing the risks and benefits of people returning to work and the long-term vision of hybrid working?
I think the experience of the pandemic and the fact that many thousands of our fellow citizens have had to work from home, I think has demonstrated the potential for different models of working. And for some people, that has been beneficial. They have been able to organise their lives in a way that has enabled them to sustain their lives, undertake all the rest of what has to go into various people's days, and actually perhaps have slightly less congested life at the end of it as a consequence. For others, it's not been as successful. For others, I think it's been a challenge, and the need for social interaction in an office environment has been something that many people have or in a working environment is something that many people have missed. And then there obviously are, of course, economic implications for town centres, as you put to me, Convener. There are also benefits in relation to a reduction in traffic movement. So, you know, in my anecdotal experience, the journey into Edinburgh by car on a reasonably frequent basis is a good deal more straightforward than it's been for most of the last 10 years of my life. So there are ups and downs, but there are implications which for our town centres in relation to footfall. I think part of the response to this has got to be, I think, at individual business level, where businesses have got to work out their way of working, and they should do that in dialogue with their staff. And the government certainly is not going to prescribe a model that has got to prevail. That would be inappropriate for the government to do so. But we do encourage hybrid working, and in this context of the pandemic, and we encourage employers to have that discussion with their teams. Equally, we have to look as public authorities, government, local authorities, at the appropriate future strategies for town centres. Town centres have been facing challenges for many, many years. This is not a new phenomenon. And obviously the upsurge in online trading has changed much of the approach around town centres. But there have been a number of imaginative redevelopments of town centres, repurposing of town centres, which is possible as places of leisure, as places of residence, and as opposed to exclusively places of a retail environment. And certainly the government is engaging with a range of local authorities and communities on what that repurposing might look like, and we'll work with public authorities as effective as we can to try to address these issues.
Thank you very much. Deputy First Minister, I totally agree, and in South Asia and in Ayr we are looking at repurposing Ayr Town Centre, bringing in residential and leisure as well. Can I move on to Murdo Fraser?
Well, thank you, Convener. Good morning, Cabinet Secretary and Professor Leach. Can I just start by picking up just on that last point from the Convener about return to office working? I think it's very fair to say that many employers will be moving to a hybrid model. Can you tell us what are the Scottish Government's own plans in relation to this?
Well, we have gone to a model of hybrid working, so we have more civil servants back in the working, the formal office environment this week, in line with the guidance the government set out. The Permanent Secretary made clear the approach to hybrid working should take its course, and staff are working on that basis as we speak. So the Scottish Government has followed the guidance that we have issued for others, and that's being applied across the working environment.
Thanks. I mean, there was a press story I spotted earlier in the week that suggested that fewer than 5% of the Scottish Government staff at Victoria Quay were turning up for work. Is that correct? And would that be a level you would expect, or would you not expect it to be higher?
Well, I would be I'd be surprised at that. I don't have the data in front of me. I'll explore that data, and if there's some data I can share with the committee, I'll happily do so. But I think the move to hybrid working is a welcome one, and I know it will be embraced by civil servants as it's been embraced by the leadership of the organisation, setting out what we expect of staff.
You'd expect more than 5% to be coming to the office?
Yeah.
Okay, thanks. Can I ask a separate question perhaps to Professor Leach? We've heard a lot in the last week or so about the BA2 subvariant of Omicron. How worried should we be by this?
Mildly. It appears in the early research to have one advantage. It's tricky, and this committee knows how this works now. It's tricky to be sure in the early stages. But what we call the secondary attack rate, which is the number of people who get it when a positive arrives, particularly in a household, for example, appears to be slightly higher with BA2 than it was with BA1, which is the original Omicron, 29% versus 39%. So, in rough terms, 40% of people in a household get BA2 if somebody has it, 30% get BA1 if somebody has it. It's not a huge difference, but it would appear that it has a slight advantage. Denmark, BA2 is now crossing over BA1 and taking over. We expect to see that probably around the rest of the world now. But the good news is that it doesn't cause more severe disease. So you may be slightly more likely to catch it, particularly if you're unboosted, but you won't end up sicker than you would have with Omicron. Remember, milder disease is not mild. It can still be very, very bad, but we shouldn't be overly concerned about it. The other quickly different thing about this one, remember, is BA2 has come from Omicron. That's quite unusual. What usually happens is they come from a common ancestor, which is why the hope in the media and social media around viruses always become more mild, in fact, is not the case. They can go back to the original ancestor and find a more nasty route. So this one has come from the original Omicron. It appears to have split at some point in its family tree. So it may have come at the same time as the original Omicron. Nobody can be absolutely certain. So for now, the fundamental answer is mildly worried. We're monitoring around the world, but there is no more severe disease as yet.
Okay, thank you. That's very helpful. Just to follow up on one point there, if somebody has had BA1, can they then be infected with BA2?
Yes, you can get any version of it again. It's very unlikely within 3 months, but not impossible. But one of the things we're seeing with Omicron compared to Delta and Alpha is higher reinfection rates. Everything about this virus is coming down to immunity. We've learned in 2 years that one of the things to look at constantly is the WHO's risk assessment of what causes severe disease in people. So originally that list included respiratory disease, diabetes, heart disease, because nobody knew what this disease actually caused. Now, those things still increase your risk a little, but that list is now principally about people who have lowered immunity. So that could be the over 60s, the over 70s, the over 80s, who just have natural lowered immunity. Or it could be those who have had a kidney transplant, or those who are having chemotherapy. So everything about this disease is about immunity. People who are less immune do worse. Of course, the vaccination is the natural experiment of how to deal with that. But reinfection, boosted reinfection, is rarer than unboosted reinfection, but it is still a problem. If you get it fast, it's milder. If there's a longer gap, naturally your immunity has waned, you can still get quite severe disease. They're talking about 10–15% reinfection rates with this most recent virus.
Okay. Thanks, that's very helpful. Maybe, Camille, I've got time for one more question. Go back to the Cabinet Secretary again on a slightly different topic. We've been hearing from hospitality businesses who still haven't received financial support. They were told back in December, mid-December, early December, that they would be restricted for the Hogmanay and Christmas period. They've suffered significant financial losses. We're now at the beginning of February and they haven't received payments. Can you give us any update as when businesses can expect to get paid out?
Well, obviously, there's a process that's been gone through to verify that payments are appropriate, but all local authorities are now making these payments. So the system is active and working and making payments in all parts of the country. Obviously, individual local authorities will work to their own pace, but we would encourage them to move as quickly as possible, since the resources are available to be distributed. And I certainly would be very keen to encourage all local authorities to resolve any payments as quickly as possible. It's really important that businesses receive these payments, but it's equally important that it's appropriate that they receive these payments, so the necessary checks have got to be made to ensure we're confident about the spending of public money.
Okay, thank you. Thank you, Commissioner.
Sorry, that was my fault. Alex Rowley.
Morning. Could I maybe start with, I think every MSP will be getting a lot of emails with regard to schools and the wearing of, continuing wearing face masks. But, and also if you read the headlines in all the papers this morning, I mean, I see one here, door chop is totally unhinged, but every one of the newspapers seem to be having a go at the announcement yesterday. But specifically, I note that Hugh Pennington said, and I quote, "I'm not sure how much science is behind it. I'm sceptical." Maybe if I put glasses on. I'm sceptical it's going to make much of a difference. It really has shown that something is being done for its own sake. What is the evidence behind that? And your own authority, Mr Swinney, Perth and Kinross Council, they make clear in the Courier today that they've dismissed the government's proposals to chop the bottom of classroom doors to improve ventilation in schools. So where are we at with the schools? Where are we at? I mean, parents are rightly concerned that education, that kids have lost a lot of education over the last period of time. There is a view that having to continue to wear face coverings in school when we're not seeing face coverings being worn in many other places is a distraction and gets in the road of education. We then have all these measures yesterday cutting off the bottom of doors. Local authorities, should we not be actually empowering local authorities more for them to actually produce detailed reports that show what's happening in the schools, where they're at, and for them to take the responsible steps that they believe need to be taken at the local level? Or is this centralised control of 32 education authorities with a whole load of measures the right way to do it?
Well, where do I start with that one? There's moments, Mr Rowley, in my tenure as Education Secretary where I would have loved to have exercised more control over local authorities and their performance on education, believe you me. And the scenario that you put to me, Mr Rowley, is that the government has empowered local authorities because local authorities, well, the government has no need to empower local authorities to do these things. Local authorities have the statutory responsibility for the delivery of education and the maintenance of the education estate within Scotland. So local authorities were invited some months ago by the government to set out what steps they were taking to improve ventilation. All of the responsibility, all of the scope lies exclusively in the hands of local government. Now, what the government, of course, has done has been to make resources available to local authorities to try to help them to fulfil their statutory obligations in maintaining the school estate, ensuring there's good ventilation available. So there's no centralised control here. There is guidance that will be formulated having taken expert advice, which will be signed off by the Education Recovery Group, which of course includes local authorities. Local authorities are heavily represented on the Education Recovery Group. They'll be heavily involved in the formulation of the guidance, so, but they have the scope, and indeed the government has, and the Education Secretary has reported to Parliament before, about the feedback that she's had from local authorities about the steps that they're taking in relation to the improvement of ventilation. Now, on the other issue that Mr Rowley puts to me in relation to face coverings in schools, there is a different set of circumstances exists here, because the school-age population where we are requiring that face coverings continue to be worn are less vaccinated than the rest of the population because of the timing of the advice from the Joint Committee on Vaccination and Immunisation. So when we look at the infection levels, there has clearly been a higher preponderance of infection amongst younger people, generally over Omicron. That's a summary position, but generally that's been the position. In the absence of as high levels of vaccination, because of the timing of the JCVI advice, we judge that it's a proportionate step to maintain the wearing of face coverings within schools, but of course that will be an issue that is reviewed on a regular basis by government, but we consider it still to be proportionate to protect young people and staff in the school environment.
I just wonder, I mean, you know, my daughter's a principal teacher in a high school, so I do talk to her constantly about the challenges. I'm well aware of the challenges that are in schools. But it's just this idea that the government come forward and say, we'll put 2.4 million into mechanical fans and 300,000 for doors to be undercut. And I just wonder how you come up with that that's the solution, and how engaged local authorities are, and do we at a local authority level actually have some kind of report that says here are the challenges in our authority. So for me, looking at that, and back to Hugh Pennican's point where he says there doesn't seem to be any real evidence, it's almost like being seen to do something. You know, where is the evidence? Where is the evidence that actually spending £300,000 cutting the bottom of doors in schools is actually going to be the answer?
In formulating any guidance, the government draws on evidence from a range of different sources and looks at that evidence, considers that evidence and makes appropriate judgments. It takes, I know from my experience in chairing the Education Recovery Group for a sustained period during the last few years, we engage significantly with local authorities on all aspects of the formulation of that guidance. So local authorities will be involved in the development of all of this thinking. And I come back to the point I made to Mr Rowley in my earlier answer, that the government has sought from local authorities assurance that they are taking all the necessary steps to configure their estate to ensure there is appropriate steps in relation to ventilation, and that will vary from classroom to classroom, to school. So I accept the point that Mr Rowley is making to me, that this is something that is fundamentally has to be handled at a local level, but that's exactly what the government has done.
Okay, thanks. Can I move quickly on to ask you about the NHS and the backlog? I did raise, I think, a number of months ago, the rise of the private sector in Scotland, and that seems to be, the rise of the private sector in Scotland seems to be increasing. I had a constituent that I'm taking a case up with just now, where she was going to the Murrayfield private hospital, had paid £200 to see a consultant, was quoted £14,500 to get a hip replacement. 2 days before was told that would be £15,500, take it or leave it, because there's lots of people looking for them, and that's the private sector. But what about the people who can't afford to pay the £15,500 and the £200 to get their hip replaced? And are we going to start to see detail, authority by a health authority of the backlog, and specifically where that backlog is? There's a lot of people out there in a lot of pain that have been on waiting lists for things like hip replacements, cardiacs and whatever, and you can see why there's a growth in the private sector. But fundamentally, that's basically the NHS failing to be able to meet the basic health needs of people. So where are we at? What are the waiting lists and waiting times looking like? And how are we going to tackle that, other than saying to people who can afford that, then they can go to the private sector, and if you're poor, you can stay in pain?
I think there's quite a number of points that have got to be made in response to that question. The first is that we've had a global pandemic which has affected our delivery of healthcare for the last 2 years, and I think it's I think the committee has got to be very careful that it doesn't forget about the fact that we've had a very disruptive global pandemic that's put enormous pressure on our health service. And I think that's, I make that point bluntly to the committee, that we can't just wish away the last 2 years, because the last 2 years have been hugely disruptive to the health service. Second point I'd make is that throughout the period of the pandemic, the health service has maintained as large a range of core services as it possibly can do. And in some treatments, for example, for cancer, that has been sustained throughout the lifespan of the pandemic. There are other treatments where we have had, of an elective nature, where we have had less capacity because we've had to allocate capacity to deal with the pandemic. Indeed, I'm reminded that there's been some quite significant resistance to some of the measures the government has taken to try to protect capacity in the health service by putting restrictions onto the general population. Some of these measures have been resisted within Parliament, but if the government hadn't done that, even more hospital capacity would have been used up to deal with COVID rather than dealing with other cases. So hard choices have had to be made, and I regret the fact that as a consequence of that, some members of the public are waiting longer for treatment than they should have to wait. The third point I would make is that obviously there is a whole programme of recovery underway to ensure that people can receive the treatment to which they are entitled. That work is underway now, and we're seeing an expansion of elective treatment. The more we can suppress COVID numbers and COVID hospital admissions, the more scope there is for other treatments to be taken forward. In relation to, finally, the publication of data on those who are waiting, waiting times data is very frequently, I think it's available on a monthly basis?
Some are weekly, some are monthly.
Yeah, so there'll be a range of data that's available. I would be surprised if that is not available at Health Board level. It will be available at Health Board level. So all of that data about who's waiting, how long they're waiting, is publicly available. And obviously what that data will show is that people today in a whole number of different disciplines are waiting longer than they would have waited pre-pandemic. But we are working hard to make sure that we address that and address it as quickly as we can do.
Quickly, I certainly am not criticising anybody within the NHS, and I've never criticised the government for the steps that they've had to take throughout this, and I've certainly supported it. However, and whilst you can rake through the data and find, so NHS 5, I can see a lot of that information here. What's not clear to me is when we're going to actually start getting in about tackling that, or whether we've actually got a plan to tackle it. And the only option that seems to be available right now for people who are on long waiting lists for types of operation like hip replacements, etc., is the private sector. And therefore you have a two-tier system of health currently operating on the ability to pay. And all I ask is we need to start to see much more evidence of the government's plans to start to tackle this.
Well, what I reassure Mr Rowley about is that the government is already investing £1 billion in the NHS recovery plan, in excess of £1 billion in the NHS recovery plan, to do exactly what Mr Rowley is asking of us. And it's appropriate and important that we do exactly that. The second thing I would say is that there is limited private sector capacity within Scotland. So I think the priority for the government is to make sure that we are working with health boards to suppress COVID, maximise the capacity that's available for non-COVID healthcare, so that we can rebalance the health service and that we don't have to return to the situation we've regrettably been in for the last 2 years of having to allocate an increasing proportion of our healthcare resources to the dealing with COVID, that we can begin to rebalance that to deal with the routine treatments, which it is important that we address.
Thank you.
Thank you. Can I bring in Jim Fairley, please?
Thank you, Convener. My colleague Alec Rowley has just quoted Professor Hugh Pennington twice. He's a highly regarded Professor Emeritus of Bacteriology. we've had in this committee advice that ventilation in schools could be as easy as cracking open a door. So if you, as a government, were looking for advice on how to maximise the ability to keep your ventilation right, would you go to a professor of bacteriology?
Well, there's a variety of sources that the government would go to. There's a lot of expert opinion. During my time as Education Secretary, I spent a fascinating amount of time talking to Professor Kath Noakes, who, if my memory serves me right, is a professor in Leeds University, I think, but a renowned expert on ventilation, who provided substantive advice to me personally on these questions. So obviously there's a lot of good advice available for us on these questions. It's important we take it from the people with the right discipline of view.
Which is exactly my point. I would contest that the Sun's article quoting Professor Hugh Pennington is perhaps not fair to the public to get a message, because they'll hear professor, he must know what he's talking about. But he's a professor of bacteriology.
It's perhaps not for me to discuss and question the motivations of media coverage. If we're going to do that, we'll be here a long time, I suspect, Convener.
Right. The point I'm making is on messaging. And we hear the daily figures, we're getting the daily figures from the government about number of infections, number of deaths, number of ICUs. We've clearly got a problem right now with backlogs of cancer diagnosis, cancer treatments. I've spoken in this committee before about the heartbreak of some of my own constituents. So what would be the effect from the government's messaging point of view if we were to start publishing every day how many people were diagnosed with cancer, how many people were diagnosed with heart disease, how many people were diagnosed as having had a stroke, and how many deaths were in each of those illnesses? Would that make people less concerned about approaching their NHS and say, I better get myself checked, and hopefully start to catch up on some of the latent disease that is clearly lying in the community at the moment?
There is and this really relates to the answer I gave to Mr Rowley a second ago, and I'll maybe bring in Professor Leach on this point as well. There is a substantial amount of data already published on the number of people receiving treatment for particular conditions and the number of people waiting for treatment for a range of conditions and the length of time that those individuals are waiting. So I think there's a pretty wide cross-section of information that is available on that question that allows the public to judge what progress has been made in addressing the health challenges that we face. Obviously, members of the public will be able to look at performance today compared with performance during the pandemic at its height and performance prior to the pandemic to see the comparative situation that we find ourselves in with the disruption that the pandemic has created. But certainly what I would want to assure the committee about is that the government is taking steps to ensure that as much as possible is done within the health service recovery plans, within the capacity that we have and the capacity that we are creating to ensure that any backlog of treatment is properly and fully addressed. But I think the data sets are available for us to judge the performance in that question. But could I come in
just before you go to Professor Leach there? I'm not disputing the fact that the government have this data out there. I'm not disputing the fact that the government have modes of allowing people to understand what's going on. But every day we talk about COVID deaths, COVID hospitalisation, and it has clearly created a behaviour in our society that says, COVID, we must react, we must deal with that. We don't have the same levels of reaction to cancer or to any of the diseases that kill people in large numbers every year in Scotland. So my question is a changing of our behaviour to get the community to say, yeah, this is as dangerous or more so than what COVID is. So it's changing that message. So if we presented daily figures, these are the number of people today who died of cancer, might just have that same effect.
Well, I think I would contest a bit of what Mr. Fairley puts to me, because if I think back to my time in this Parliament over the years, you know, when I came in here 23 years ago, deaths from cancer, heart disease, strokes were significantly worse than they are today. And successive governments concentrated their messaging and measures on proactive interventions to try to address that. So you'd have screening programmes that would be introduced that would raise awareness about the degree of risk that individuals had from particular conditions. And messaging campaigns were put out to raise public awareness about symptoms, about signs, about the availability of screening programmes, to try to reduce those numbers of deaths. And those programmes have by and large delivered better outcomes, if not taken away. Obviously, they're still, sadly, people still die from these conditions, but fewer people are dying from these conditions as a consequence of the investment that's been made in messaging to raise awareness on these points. So I think what I would say to Mr. Fairley is that we have to focus public attention just now on COVID because of the threat it continues to pose to our population. But there are other threats out there that we absolutely need to raise awareness about, and we need to get public behaviour to comply with some of those threats to make sure they can be properly addressed.
I have some sympathy with your position, but I think your solution is probably a little blunt. So I think your public health messaging theory is good. There has been a kind of intermittent clamour for 2 years around the world to say to the BBC, why do you just talk about COVID? Why don't you talk about cancer every day? I think it's misguided. We are in 2 years into an emergency public health global situation that's killed at least 5.5 million people. We're not in normal times anywhere in the world, not anything like normal times. We do publish cause of death data for excess deaths, for disease groups. We don't do that daily. There's a huge amount of resource even in getting daily data for a single disease like COVID. And I think the public would soon switch off. Our behavioural experts in communication agree with you that we should get public health messaging out, of course, about obesity, about nutrition, about fitness and all of those other things. But daily deaths by disease is not the way to do that. You should, of course, use those elements inside your communication more broadly. The other thing is it is often used... No, you're not doing this. I think we know each other well enough to know that this is not where you're coming from. But that question is often used to underplay COVID. So there is often a suggestion in those who ask for that we are overreacting to COVID. That is misguided. We're not. The way to get the waiting times down, the way to get back to the public health of the population out of COVID is to get COVID down and keep it down, because that releases you resource, it releases you people, and it allows people to get back to some form of normal. So I like your diagnosis. I'm not sure I'm with you for your treatment.
I'm awful glad you clarified that prior point as well. I'm probably more cautious than normal.
Yes, you are.
Can I... Time for one very quick one. I'd like to know where we are on long COVID in terms of our understanding of it and the effect that we're having and how we're treating it.
New news every day, every week with a new disease. Let me just remind you, COVID didn't exist 2 years ago. It's a brand new infectious disease, and we haven't taken anything away. So we've layered this on top of what already exists. It appears to be a complex post-viral syndrome that most people recover from within 12 weeks. So quite a lot of people have a lingering post-viral disease, but you get that with all viruses. Measles does that to some kids. Glandular fever does it to some people. So the vast majority of people recover with general support within 3 months. After 3 months, there are some who still feel some symptoms. Those symptoms vary hugely. There's a very long list. Probably tiredness and fatigue is the most common, but also some people are still reporting gastrointestinal symptoms. Some people are reporting breathing symptoms. What we are doing is, 1, investing in research, 2, providing resource to the health and social care system to care, and we're allowing the health and social care system to decide what that should look like. In some places, that will be a single point of contact, the so-called long COVID clinic. But if you imagine coming with a very complex syndromic disease, you're not coming with an insulin requirement or a breathing difficulty. You're coming with maybe 20 groups of people with 30 symptoms. There isn't a single doctor in the world who can do that for you. It's impossible. You have to have some way of getting that single point of contact. But you might need physio, you might need diagnostics, you might need neurology. So all of that has to come, and this is how the health service works. So you come in a front door, that front door will probably be your general practitioner, and that front door should then open to you to all the available doors beyond that front door. That's how we're trying to deal with long COVID. If the situation changes, if we get more knowledge of it, perhaps treatment, some of the antivirals in the acute disease appear to perhaps reduce your chances of long COVID. All of those things we'll take into account just as soon as we get that research.
Thank you. Thank you. Can I move to Brian Whittle, please?
Good morning, Professor Leach. I just thought a very quick point actually on some earlier discussion around the hybrid working. One point that's been made to me by a number of companies in that if we do end up in a hybrid working system, as has been discussed, there are a lot of companies out there who have a 10 or a 15-year lease on office space, and that has to be, they have to take that into account. So there's a cost in delivering a hybrid working model, but the costs they had pre-pandemic remain. I don't know whether that's something that the government have considered or taken into account.
I think that's really why I come back to my point in answer to Mr Fraser earlier on, that individual companies have got to assess how they take forward their working environment as a consequence of the pandemic. I think the substantive point I was making is that some organisations have probably found that it is possible to undertake a lot more tasks out with an office or workplace environment than they perhaps thought was the case before. And that obviously then affects their way of working. There will be consequences of adopting that as a more permanent model, which will be some of the issues that Mr Whittle puts to me in relation to leasing costs for premises, but individual companies would have to consider whether they could sustain that and whether that would be the appropriate approach for them to take.
I think you know, no one will labour this point, but I think the worry there is that in those particular circumstances there might be a thought of leaning on their employees to get back into the office.
Well, I think I would be certainly very much against that. I don't think that's good, fair work practice to use the terminology, lean on one's employees. I don't think that's the way to think about the world at all. I think there's a lot of business organisations who I think realise that it is now possible to operate in a different fashion, to perhaps have a more productive working environment. And certainly when I think about some of the challenges that people go through in relation to the travel time they might experience in getting to work and all the rest of it, that some of that can be saved and can be put to better productive use. So I think it's essentially the way through this is best taken forward by dialogue between employers and employees to make sure that the correct approach is taken.
Yeah, and I think from a business perspective, Mr. Swain, I'm not very, again, don't want to labour this, that you know, when a business is under that kind of pressure and financial pressure, you know, these decisions, I'm just putting it out that these have to be made. Can I go on to what where my real interest lies, just following on from my colleague Jim Fairley there. I think one of the things that COVID has shown us is how much we can change, you know, societal behaviour in such a short space of time. but as to the point that Mr. Fairley makes, that there are many conditions such as obesity and diabetes and heart disease and whatnot, and some cancers and even mental health and whatnot, that can be positively impacted by behaviour. And one of the things that interests me around this is that these conditions have a higher, more of a population die from these conditions than COVID, albeit that it's an emergency situation. What have we learned in that? Coming out the back of COVID, we have an opportunity in my book here to try and change this unhealthy part of Europe that we live in. How do we use what we've learned from COVID to change societal behaviour for the betterment of the health of Scotland?
I think there's a really significant issue and opportunity here, and I think I think in the way that Mr. Whittle puts it to me, it's almost like a moment to reset many of our attitudes in this respect. Professor Leach will say a little bit in a moment to give a much more substantive clinical opinion than the one I'm just about to give the committee. From my long-standing clinical and epidemiological background. But fundamentally, I think what the pandemic has told us is that the healthier you are to deal with some form of adversity to your health, the better your chances are of weathering it. Now, that's not, there are some healthy people who have been absolutely felled by COVID, but generally, I think keeping yourself in a good state of health is an important prerequisite to handling any situation. And I think the opportunity is there for us to reinforce some messages which have been around for a long time, but I think need to be reinforced about our own individual responsibility and opportunity to lead as healthy a life as we possibly can do. I know for, of the importance of that in relation to making sure people are physically healthy, that they are eating well, that they're exercising. These very, very routine, several times a day factors can be significant in relation to the amount of weight that we carry, how we feel, how much energy we have got. I know if I go for a run in the morning before I start my working day, I generally have a better day because I've looked after myself in the morning before I've come to my work. All these things count together. I know these things will resonate with Mr. Whittle. Us athletes have got to stick together. So there is a very serious point that Mr. Whittle makes, that there is an opportunity, and this comes into some of the issues that Mr. Fairley was putting to me about public awareness. Some of the messaging we need to be putting out about our own health and well-being has to equip people with some of the ideas and the arguments that enable them to be physically as capable to withstand some of the issues that COVID can throw at us. Well, I invite Professor Leach to add to that.
I think your fundamental assessment is correct. I would just mention professional athlete versus the amateur athletes who are at the front of the room, perhaps. But I think there is a moment, I think you're right, Mr. Whittle, and I think we would do well to take advantage of it. I think part of that responsibility is the public health communicators, mine. Part of that responsibility is other stakeholders, MSPs. I think there is a moment for all of you to take advantage of the platforms you have with your populations that you serve and make those same points. I think COVID has given a literacy to the population that is probably unique in our lifetimes around how to protect yourself, vaccination programs, how to look after yourself, how to look after each other. And your fundamental point is correct, Deputy First Minister, that the healthier you are, the more likely you are to brave infectious disease. You're not immune, but the more likely you are. And I think the country's learned a lot about risk. Not everybody, because not everybody understands that concept, but a lot of people have understood that if I do these things, my risk falls. It's not going to be 100%, it might come down just a little bit. The only final thing I wrote down here was kindness. I think the population has learned a great deal about looking after each other. Now, that was probably already there, But I think COVID has brought that out, and I hope we don't lose that, because I think that's also important for public health, for the elderly, for the more vulnerable, for the homeless, for all those groups that we've looked after as neighbours and friends around the population, and I hope we keep some of that.
I have to say, thank you very much for calling me a professional athlete. I think that finished a good 2 stone ago. Yes, muscle so much heavier than fat. Anyway, I think this is a massively important point here, is that I think we do have a huge opportunity here to reset. Maybe contrary to the approach that Mr. Fairley talked about, publishing the sort of data, that kind of data, I would like to think we could do it from a positive side of things, which means opening up opportunity, which has been curtailed significantly during COVID, and that to impact at a level, we're going to have to not just go back to the opportunity we had before, but we're going to have to go much further. I'd just like to understand where the government's thinking in this is. Anecdotally, I know that I'm still doing athletics coaching, and we have limited access to the track. It's only open at certain times, which I don't understand. My mother can't go to her exercise classes at the moment. So how? It's not just about getting back to where we were. It's how do we take that and take this opportunity and go much further.
I think there'll be a set of events and arrangements that have not yet restarted. If I take the example of Mr. Whittle's mother's exercise class, obviously we are trying to get all of these arrangements back up and running as soon as possible. My father's exercise class has been going on for some time, and he goes to it, and it's great for him, and I'm delighted that he does that. So there'll be some of those events that we're trying to get up and running and get them back, and we're now in a position where that is now plausible because of the improvement in the general situation around about COVID. I think there's another set of circumstances, again in the question that Mr. Whittle puts to me, whereby there are public facilities which stand locked up quite a lot, and there is no good, real, rational reason for that, and we need to be maximising the use of these public facilities. Some of that, of course, may be tied up in the contractual arrangements that procured some of these facilities, and I would encourage public authorities to try to stretch those and to make sure they are not an impediment to the use of these facilities, because the activities that Mr. Whittle has talked about are possible within communities if there is access to facilities that are appropriate for that exercise. I think there's a third element, which is about general messaging, which tries to get to the point of principle that Professor Leach was talking about, which is basically the healthier that you are, the greater your ability to withstand the adversities that might come your way in terms of your health. So encouraging public messaging around about exercise and about looking after your individual health is critical as part of the preventative health interventions that we are able to take forward. And then lastly, I do think, and there is very good examples of this within the health service, of health interventions being designed, and I say this for simplicity, not by the drugs that are being prescribed, but by the exercise that is being prescribed. So health professionals increasingly trying to say to people, look, you'd be better off joining an exercise class than me giving you something of a prescriptive nature. And I think that's very important in winning hearts and minds about how we can all individually take steps to strengthen our own health and well-being.
But the opportunity has to exist, and I think that's where I'm really going with this, Mr. Smalley. The government's responsibility here, I think, is to create the opportunity, and then or make that opportunity available, and then the messaging.
Yeah, yes, where we can do, but I would simply say that the government, to my knowledge, doesn't run any leisure facilities in the country. we are hugely dependent on local authorities for the running of leisure facilities around the country. So I suppose and that's not me, I'm not sort of trying to split hairs here, it's a very practical point. I would encourage local authorities in deciding their own priorities that they create the opportunities for the exercise events that take place. There's also, I think, an obligation on, if I think back to some really good examples I've seen in my own constituency where, for example, health professionals have gone along to lunch clubs for senior citizens and persuaded them to get involved in some, as well as having a bowl of soup and a sandwich, a wee bit of exercise, sitting in their chairs before they have their soup and sandwiches. And it makes all, and now that's a health professional going along to an event in a community and engaging people, and people thinking, well, that was a great intervention. It's helped to strengthen the mobility and to push against the frailty of some of our senior citizens. So there are simple things that can be done, and what I would assure Mr Whittle about is the government will be engaged in that in terms of messaging and in terms of substance where we're able to do so.
Thank you. Can I bring in John Mason, please?
Thank you very much, Convener. And yeah, I've got a few questions, I think. Before Christmas, when we heard about Omicron, the message from South Africa seemed to be that it was transmitting faster but wasn't so serious. But there was various reasons given why we maybe shouldn't just accept that as being the same here, because South Africa's got a different climate and the population's younger and things like that. But I just wonder, looking back on that, should we have just accepted the South African experience more readily?
I don't think so, and I think the evidence bears out why that's the case. In my opening remarks, I talked about the fact that we are in a much stronger position in relation to hospital, the number of people in hospital with COVID, although it's falling, it is still double what it was just before Christmas. Now, I used language in this committee before Christmas and externally, which warned about the galloping nature of Omicron and what that would do to hospital admissions, and it did so. And hospital admissions reached very significant levels. I think the highest, the number of people in hospital with COVID at its height came very close to 1,700. That was, a comparatively very high level, and it got there very, very quickly at a time when the rest of the health system was under the acute pressures of winter and all that that brings. So I think what the preventative measures that we put in place, I think were necessary to avoid us getting to a position where our health service was overwhelmed. And looking at the pace of the increase in hospital admissions that took place prior to Christmas, if we had not acted, if we just allowed Omicron to take its course, then I could be pretty certain the health service would have been overwhelmed. I don't know if you want to add to that.
Uncharacteristically briefly, we should accept anecdote from nowhere and evidence from everywhere. So when the South Africans had evidence, we accepted it. When the South Africans had anecdote, we did not.
Okay, thanks for that. Moving kind of on to vaccination, we get the figures every week or so from SPICE about how many people have been vaccinated, including specifically ethnic minorities, people, different levels of deprivation and age and so on, and the cities. And I just wonder, we don't seem to be making much progress. All of the four cities or the four main cities, I should say, are still in the 60% for having had the booster. That seems to have been kind of fairly static for a while now. Should we be relaxed about that, or is there a problem, or are we just accepting that we cannot make progress on this?
We certainly shouldn't be relaxed about it, and we shouldn't resign ourselves to that, which is why, frankly, every single possible element of invitation that we can possibly make to get the booster vaccination is being undertaken just now. So, for example, but there's been, in the run-up to the turn of the year, the volume of messaging and communication to encourage people to come forward for the booster vaccination was colossal, and we've made very significant progress in that respect. We were within clipping distance of 80% of the eligible population being reached by the 31st of December. We are now deploying a whole range of other interventions, including directly writing to everybody who has been vaccinated with the first and second doses, but has not yet been vaccinated with the booster dose, to encourage them to do so and to provide them with the means of doing so. There are still extensive walk-in facilities available all around the country, but particularly in our cities, and they are there to make sure that people have ready access to opportunities of this type. So we certainly, in a variety of different steps in relation to communication and in a variety of different steps in relation to practical availability, then the steps have been taken to make sure that people can have access to vaccination, and it's not something we should give up on whatsoever.
Okay.
I don't know if you want to add.
I think that fundamentally covers it. There are some stragglers in there who will never come. There are some who require questions answered. We're trying our best to get to them, whether they're young people, whether they're Polish who are quite vaccine sceptical as a country, for example. We've talked about that before here. And whether there are ethnic minority groups who particularly need it, the language in a literate way that they and their community leaders can understand. So we're trying to tackle each of them. Some of those 60s are because they're not quite ready. So we've managed to get them for a second, but they're not quite ready for their booster yet. But I think you're right. I think the cities in general, broader populations, less vaccinated, and we should tackle that as best we can. We've got vaccine leads in each health board who are trying to do kind of bespoke type comms, bespoke type delivery to each of those communities or sets of communities as we possibly can. Everything MSPs can do to help, they should absolutely do to help.
Okay, thank you. Sticking to the vaccine theme, where are we with 5 to 11-year-olds then? Has there been any change in the JCVI thinking, or are we is it still just the vulnerable ones?
It's to the young children in that age group who are clinically vulnerable, and to the children within households where there is a clinically vulnerable adult. So those two groups are now the subject of the rollout of the vaccination, and that's now underway in different parts of the country.
Do we know, are JCVI looking at just all 5 to 11-year-olds, or is that not on the table?
They're constantly looking at it. Their position just now is that they are not recommending it. It's not a supply problem, it's a public health decision. It's a risk-benefit decision for them. We now have paediatric Pfizer in the country, and we're able to give paediatric Pfizer. We don't have much, but that's not the JCVI's problem. The JCVI will not make the decision based on supply. We will then have to make choices if they say 5 to 11-year-olds as we try and buy more Pfizer paediatric, which is now being used around the world. Their present position, and they reinforced this either last week or the week before, was that they're not presently recommending all 5 to 11-year-olds. That could change any week, frankly.
Okay, and looking forward then to future boosters or vaccinations, I mean, we had thought, well, we know that the protection immunity wanes over time. So what is the present thinking about when would people need, say, a fourth one? Would it be before next winter or before that, or what?
The JCVI have considered and decided not to recommend a further booster vaccination, which would be a fourth booster for over 80s, although they considered specifically that proposition. We obviously await further advice from the JCVI on what might become the the more routine approach to vaccination for future programmes. Obviously, that depends significantly on the course of the pandemic and what we experience between now and then, whether a new variant, I come back to the point I've rehearsed with committee before. Cabinet in late November took a view on a Tuesday that the pandemic was quite benign. By Thursday, we were on Omicron. So the things can change very, very quickly. So we essentially stand ready to deploy whatever is necessary to deliver the vaccination advice that we receive from the Joint Committee on Vaccination and Immunisation. I think what is reassuring is that we have had a solid experience of the delivery of a colossal vaccination programme with significant efficiency and effectiveness. And that should give us confidence that we can pivot to take forward whatever proposals are put to us by the JCVI.
Okay, and my final area, I think, would just be to ask you about the strategic framework. I mean, you said, I think that's going to be published in about 3 weeks' time, maybe after the recess. Can you say anything more about it, the kind of way we're heading, or will it continue to be a kind of gradual, step-by-step approach?
What we want to do here, and the reason why we're taking time to gather evidence and to consult, is that we would rather put into place a strategic framework that has a significant longevity about it to give confidence and certainty to people as to how we intend to position ourselves to manage the pandemic. We hope we have the opportunity to do that we are in a slightly becalmed situation just now, which enables us to set out what's our assessment of the current situation and our view of what approaches may be necessary to manage the pandemic on an ongoing basis, and what might be the steps that we would have to take should we need to intensify any of the actions that we take to deal with the pandemic. So it's a framework which we hope will have a longer perspective than perhaps some of the periods that we've experienced during the pandemic, where of necessity we have had to change some of the foundations of the framework of approach to reflect the fact that the course of the pandemic has changed quite significantly in front of us.
Okay, thank you much. Thanks, Convener.
Thank you very much. That concludes our consideration of this agenda item, and I'd like to thank the Deputy First Minister and Professor Jason Leach for their evidence today. I now move on to the second agenda item, which is consideration of motions on the made affirmative instruments considered during the previous agenda item. Deputy First Minister, would you like to make any further remarks on the SSIs listed under agenda item number 2 before we take the motions?
Convener, it may be helpful if I just place on the record some remarks about the different regulations. The committee has before it motions to approve 2 emergency health protection instruments. The Health Protection Coronavirus Requirements Scotland Amendment No. 2 Regulations 2022 implemented the second phase of the lifting of the Omicron response measures. These regulations remove indoor capacity limits for live events, remove physical distancing and table service requirements, and allow nightclubs to reopen. And with the reopening of nightclubs, the regulations also make a small change to the definition of late-night premises in relation to the certification requirements. The Health Protection Coronavirus Requirements Scotland Amendment No. 3 Regulations 22 amend face covering requirements so that in the circumstances set out in the principal regulations where a person is permitted to not wear a face covering based on being at least 2 metres away from other people, that distance is reduced to at least 1 metre. The committee also has before it 1 motion related to international travel, the No. 2 International Travel Regulations SSI 2022-25, add the new dynamic athletics event to the list of specified competitions in the principal regulations. This is an indoor athletics event due to take place on the 5th of February 2022 at the Emirates Arena in Glasgow. This amendment is made to allow for international sports people and ancillary staff coming to Scotland to compete in the event and to be eligible for elite sports person exemption. The committee also has before it regulations to expire early provisions in the Coronavirus Scotland Act 2020 at Schedule 4, paragraph 18.3, the parole board use of a live link. These provisions allowed the parole board to make use of a live link for the entirety of parole proceedings during the COVID pandemic, rather than conduct face-to-face hearings. At the same time, the Parole Board Scotland Amendment Rules 2022, laid on the 24th of January 2022, make equivalent permanent provision in the rules, which will take effect from the point of expiry. This will avoid any gap in the ability of the Parole Board to conduct remote hearings and future-proof the Parole Board's proceedings going forward, should there be a future pandemic or other reason where a face-to-face hearing would not be advisable. Thank you.
First Minister. Are members content for the motions on the agenda to be moved en bloc? Yes. Yeah. Thank you. Members are agreed to move the motions en bloc. I now invite the Deputy First Minister to move en bloc motions S6M-02894, S6M-02966 and S6M-02987.
Moved en bloc, Convener.
Thank you. Would any member like to comment? Nope. I note no member has indicated they wish to speak, so I will now put the question on the motions. The question is that motions S6M-02894, S6M-02966 and S6M-02987 be agreed. Do members agree? Yes. Agree. The motions are agreed to. The committee will publish a report to the Parliament setting out our decision on the statutory instruments considered at this meeting in due course. That concludes our consideration of this agenda item and our time with the Deputy First Minister. I'd like to thank the Deputy First Minister and Professor Jason Leach for their attendance this morning. Thank you. I now move on to the third agenda item, which is consideration of the negative instrument as listed on the agenda. The committee has had the opportunity to take evidence on this instrument under agenda item number 1. No motion has been lodged to annul the instrument. Are members content to agree that we have no recommendations to make on this instrument? Great, thank you. That concludes our consideration of this instrument. The committee's next meeting is on the 10th of February, when we will consider our work programme in private. That concludes the public part of our meeting this morning. I suspend the meeting to allow witnesses to leave, and I move the meeting to private. Thank you.